Hello again, everybody. We are going to start this semester off by talking about advanced pharmacokinetics and the movement of drugs through the body. Some of this will be a basic review, but the majority of the information presented to you today will be brand new information that is applicable to nurse anesthesia. So let's get started. The pharmacology of anesthesia is unique compared with other disciplines within medicine. The most obvious difference relates to the safety of anesthetic drugs. Most of our drugs have profound effects, such as unresponsiveness, paralysis, ventilatory depression, and hemodynamic alterations. It is often said that anesthesia is manipulation of the autonomic nervous system. We tend to create numbers that we like. If we don't like a certain blood pressure, heart rate, we give a drug, we fix it. If we want it higher, we give a drug, we make it higher. If we want it lower, we give a drug and we lower it. Understanding the physiology of that and how we are able to do that is paramount to the practice of anesthesia, because the consequences of under or overdosing anesthetics can be catastrophic. So I cannot emphasize enough how important it is to not only know the drugs, but to understand how they work at the molecular level. Another difference with anesthesia is efficacy. Anesthesia drugs necessitate immediate onset and rapid offset, right? We need to put someone to sleep. So we need to put them to sleep for a definitive amount of time. Therefore, we need to give drugs that will make them go to sleep quickly, and when the time is right, we need to make those drugs exit and clear them out so that we can wake the patient up quickly. So that is something, efficacy is something that is specific to anesthesia. The profound physiologic alterations of anesthesia must be produced on demand to ensure rapid achievement and maintenance of an anesthetic state. We want the patient during the procedure, like I said, we want to wake them up quickly and we want a rapid return to baseline when the time is appropriate. So therefore, this thorough understanding of advanced pharmacokinetic and pharmacodynamic concepts and their application to the clinical setting and the patient undergoing surgical procedure requiring an anesthetic is a must. So the objectives for this lecture, you should be able to describe how pharmacokinetics determines the movement of drugs in the body. You should be able to discuss how various disease states affect pharmacokinetic parameters of a drug. You should be able to describe volume of distribution, clearance, and half-life, and how it applies to various pharmacokinetic compartment models. And finally, you should be able to explain the physiologic processes involved in drug metabolism and elimination, and how metabolism and elimination are altered with coexisting disease. So this slide represents some clinically important questions in anesthesia pharmacology that we have to ask ourselves and know prior to giving a patient a medication. So first, what is an appropriate initial dose? Is the dose cookie cutter dose for everybody? No, it's not. We have to take into consideration, again, those other factors that can make a dose of a drug and the pharmacokinetics variable. Things such as age, extremes of age, prematurity, a newborn infant, geriatric patients, as well as patients who are morbidly obese, patients who are acutely intoxicated, patients that have chronic issues. Those things all affect the appropriate initial dose for the patient. They also affect how soon onset kicks in, and we start to see the effect of the drug that we want. So this too varies in patient populations, and it's not the same for every patient who receives, for example, fentanyl. Not every patient who has fentanyl will have the same intended effect. When will that affect peak? Some patients it's going to peak faster than other patients. And when you start going to clinicals and you're putting together those care plans, you should be able to look at your patient's comorbidities and look at their current medication lists, and that should tell you a lot about how their onset and peak effects and duration of action of their anesthetic drugs are going to be, because one of the things that we have to be able to do is to anticipate, right? Anticipate and have a backup plan ready. So you will want to look at that, and we're going to talk about that through this semester. So when will the drugs I give peak? How long will the effect last? Again, varies between individuals. Should this drug be given by a bolus? Should we give an infusion, or should we do both? When will repeat doses or infusion rate changes be necessary? Understanding steady state and context-sensitive half times are all important in understanding when we redose a patient. When should drug administration stop to promote timely emergence? This is key. If you don't stop your drug administration in a certain amount of time, you won't wake your patient up on time, and the entire room is standing there looking at you because it's been 20 minutes and they expected you to be out of the room 15 minutes ago. So understanding the kinetics and how those drugs move through the body, in addition to other variabilities, will determine when you will emerge this patient. What are the typical therapeutic target concentrations? What are the expected consequences of under-overdosing? And will a tolerance develop? Some of our drugs that we give, after a second dose, you'll start to see tachyphylaxis. So we're going to learn about that this semester, next semester as well. What factors alter dose requirements? That goes back up to that first question of what's an appropriate initial dose. What are some patient characteristics and patient factors that would require you to alter your dose by either increasing it or decreasing your dose requirements? What is the expected amount of variability in drug response? And finally, how will drug interactions influence outcomes? These are all questions that you will learn to automatically answer after you have a more in-depth knowledge of anesthesia pharmacology. Okay, this is a general pyramid schema of basically what pharmacology is. So it's a general framework for understanding what we do, and it starts from the bottom and works its way up. So in the bottom, you have your dose of your drug in a syringe, okay, and that's usually in grams or milligrams depending upon what you give, and that becomes your mass. That is something that you're able to measure, your mass of your drug, milligrams or grams. You all remember that from chemistry. So that is the bottom of the pyramid, and then you're going to inject that dose of medication into the bloodstream. So for us, our drugs, for the most part, with the exception of some of our preoperative medications, are given intravenously. And then our inhalational agents, obviously, are given through the breathing machine to the patient. So for all intents and purposes, when we talk about drug delivery, we're talking about IV or inhalational when we talk about anesthesia. So you have a dose of a drug in a syringe, and you're going to inject it into the bloodstream. This becomes your compartment. It's a volume. So now you have a certain milligram per liter per volume in your bloodstream. So that is the pharmacokinetic phase of the drug. That is the what we consider to be dose concentration relationship. So when you think of pharmacokinetics, it's the dose concentration relationship, and then how that moves through the body and what the body does with that. Okay. Then the next part of this schema is the drug at the target cell. So you inject the medication into the body, it travels through the bloodstream to its target cell. And that is that interim phase between pharmacokinetics and pharmacodynamics, and we call that the biophase. And again, that's that link between injecting the drug and the drug exerting its effects at the target receptor, which is our final step there at the top. Drug at the receptor. So that's where you're going to see the effects of your drug. It's the effect phase of pharmacology. So the concentration-effect relationship is another way that we can say pharmacodynamics. Now you're going to learn about pharmacodynamics in the next lecture. I broke these lectures up into 2 parts for this first class session so that you would have 2 separate lectures to go back and listen to and not be overwhelmed with the material. So in basic pharmacology, pharmacokinetics is typically defined as what the body does to the drug. A much better and clinical useful definition is the study of the relationship between the dose of the drug and the resulting concentrations in the body over time. That's the dose-concentration relationship. And that's when you will see these curves, these dose response, dose concentration curves. And you're going to learn about those and how to read those. In order to understand pharmacology at the level that the cRNA must understand it, you have to be able to have a firm foundation in the role of receptors. Drugs have specificity or an affinity for a particular receptor or set of receptors in the human body. That is how drugs are created. If you think about receptors and at the cellular level, we have an inherent or an innate ligand or neurotransmitter that binds to the receptors in our body at the cellular level, right? So we could use the catecholamines as an example. So we have a receptor that has an affinity for epinephrine or norepinephrine, and those neurotransmitters bind to that receptor. Dopamine would be another one, binds to the dopaminergic receptors, right? So that is what we inherently have that binds to a receptor. So all drugs are, IV drugs, oral medications, is that they replace that endogenous or inherent innate ligand or neurotransmitter because we have deficient levels in our body or we have excess levels in our body. So that is what drugs in essence do. They mimic what our body naturally produces in one form or another, either too much or too little. Or maybe they need to block a receptor if we have too much of an endogenous ligand or neurotransmitter. So when you start thinking about drugs in that regard, think about what the endogenous neurotransmitter or ligand is supposed to do at the receptor, and then that helps you to understand what the drug is intending to do at that receptor. Okay, we're going to discuss receptors and binding at the receptor in greater depth in that next lecture to follow this one, so that you'll understand the pharmacodynamics and what effects you expect to see with drug binding and drugs targeting certain tissues and their receptors. Pharmacokinetics is governed by the process of distribution of volumes. We're going to go in depth into these concepts, clearance and half-lives. As I said, receptors are front and central to this process. Proteins make up the largest group of receptors, but there are other macromolecules that can exist in a number of different conformational states that also make up some of our receptors. And then the time course of IV administered drugs is a function of volume of distribution and clearance. So when you're looking at pharmacokinetics, you're looking at the volume injected. Where does it go to? How is it distributed through the body? Okay? What is the time constant for that? What amount of time did that occur in? Okay, that's where the time course of an IV administered drug comes in. Then you're going to start looking, and once it's distributed, Metabolism and elimination. When does that take place? How many half-lives does it take to eliminate a drug from the body? That's where we go to from there. And all of this occurs over a time course. So you're looking at that movement of that drug over an amount of time from the time that that drug is injected and distributed to the time that the elimination phase begins. Okay, routes of administration. This is basic pharmacology that you all got in nursing school, so this should not be anything new to you. The amount of drug that is available once bound to a receptor is largely determined by the route of administration. The route of administration determines how much of a drug is delivered to the systemic circulation if you give a drug in its entire amount. So for instance, if you give 1 tablet of oxycodone to a patient for pain, then that 1 tablet that you give, because you gave the entire tablet, is said to be 100% bioavailable. But there are certain actions that the body takes upon the drug that changes how much of that drug is available for the target receptor. So we'll start with oral administration. It is the most common, it's the most variable, it's the safest and most economic. When you look at oral medication and as a route of administration, depending upon the drug and depending upon certain coexisting factors, 5 to 100% of the drug will be bioavailable for use at the receptor. For oral medications, we tend to primarily give those in the preoperative setting with the opioid sparing technique coming into clinical practice and us moving away from using a lot of IV opioids. We are giving our patients medications in the preoperative area that block many different receptors, multimodal therapy, if you will, and that is one of the instances in which we would give an oral medication for a procedure. The next route would be topical. It has a local site of action. Absorption is dependent upon characteristics of the skin. Depending upon the characteristics of the skin, you can have an 80 to 100% bioavailability. One of the things I did not mention with oral administration is the first pass effect, and you guys remember that from nursing school, right? Where you lose a lot of the drug in that first pass effect, so the amount that actually goes to the receptor is less than what was given. So with topical anesthetic, it's used, these are like eye drops. If you put a fentanyl patch on a patient, you have less first pass effect with these drugs, and they have a longer duration of action, so that makes them favorable. And then, like I said, the absorption is dependent upon the skin, and if the integumentary is intact and what's going on at the site. Inhalational route of administration. This is one of our primary routes of drug administration. There is a rapid delivery across a large surface area. The lungs have a very large surface area. So when you give a drug inhalational or through the breathing circuit, whether it's an endotracheal tube or an LMA, it parallels IV administration with onset. That's how fast it works. We see this with our volatiles, our steroids, bronchodilators, all go through the lungs. And one of the great things about giving volatiles, and we'll talk about that when we talk about the volatile agents in a couple weeks, is that you can rapidly titrate doses because they're breathing it in and breathing it out, and you can see how much in real time they're getting, and you can alter that, and you can titrate it to effect. Versus an IV drug, when you give it, you can't take it back, right? Once it's in there, and you better know what you're doing and what to expect from that drug when you give it, because you can't take it back once it's there. With the inhalational drugs, we're able to titrate the volatiles and be able to have a more precise control over drug administration. Okay, rectal administration bypasses portal circulation and first-pass metabolism. This route usually provides us with 30 to 100% bioavailability. There's less first-pass effect than the oral route. And, if you have a pediatric patient, you may use a rectal medication as a route of administration. Parenteral administration, that includes IV, sub-Q, IM routes, intrathecal into the subarachnoid space routes, rapid onset, can titrate the dose. It's suitable for larger volumes. There's no absorptive phase because there's a direct site of action, so you don't have to worry about the drug absorbing. You inject it, the bloodstream carries it to the target, it binds to the receptor, onset's immediate. So down below there, what you see with the asterisk is that, see if I can get this to work. This is the route of administration. So which one is faster? So when you look at this, the IV route is faster than intrathecal, which is faster than caudal, which is faster than epidural, and faster than sub-Q. Okay? IV is greater than intrathecal, meaning faster with onset, faster than caudal and epidural, and faster than sub-Q. All right, so next we'll move to absorption. Absorption is the rate at which a drug leaves its site of administration. Okay? And we're going to talk about that, and we're going to talk about factors that promote and inhibit easy passage through the membranes. Lipid or water solubility determines absorption and elimination characteristics of a drug. Okay? A drug that is more lipid soluble, and you think about our cell membranes, they're made up of lipids, right? Phospholipids. So if something is lipid soluble, that will determine how fast it moves across the cell membrane, and you would expect it to move quickly across the membrane. A water-soluble drug will not permeate through a lipid membrane, so it has to have something that helps it get across the membrane. So we're going to look at that. Absorption is defined as the rate at which a drug leaves its site of administration. Membrane transport occurs when drugs cross cell membranes by simple diffusion, by facilitated or carrier-mediated transport, and by active energy-dependent transport. We'll talk about each of those separately. You all know what simple diffusion is. It is where molecules will move down a concentration gradient. It's bidirectional, comes and goes depending upon where the least amount of molecules are. So you move from an area of greater concentration to an area of lower concentration, and so on and so forth. So passive diffusion requires no energy. It just moves along that concentration gradient. A highly lipid-soluble drug and one that has a small molecular weight will diffuse passively across cell membranes. Okay? Diffuse passively. So if it's highly lipid-soluble and it's a small molecule, small molecular weight, there are no issues with it moving across that phospholipid membrane of the cell. So that is what you see here on this left side. High lipid. There's also non-ionized. If it's non-ionized, that has to do with solubility. We're going to talk about that next week. I'm not going to go in depth on this lecture because that is a very complicated concept, and we'll talk about that next week on its own. We talked about higher concentration of the drug. Liquids or crystalloids tend to move across membranes rather quickly and easily. Blood supply. That is another factor that affects absorption. So if you have a tissue that has high blood supply, the drug's going to be carried to that tissue in a large amount, and if it's lipid soluble and low molecular weight, it will cross the membrane rather easily. And then of course heat causes vasodilation. If you dilate, that increases blood supply, which in turn will increase delivery of the drug to the target receptor. Factors that inhibit passage through the membrane are just the opposite of what we just talked about. So an ionized molecule is not active, does not move across membranes. A water-soluble drug does not easily move across membranes. Any type of medication that is a large drug with a large particle size, a high molecular weight, those drugs do not easily pass through membranes. Solids or colloids are difficult to get across, as well as having low blood flow and then low blood flow states, such as shock and vasoconstriction. So what does any of this mean to us, and why should we care? Well, most of the drugs that we give are highly lipid-soluble agents. So that is why our patients go to sleep quickly. And that is why that drug redistributes quickly. And that all has to do with lipid solubility and the movement across the membranes. If you have a patient who is in shock, let's say you have a trauma patient who has had a hemorrhagic shock and you are implementing a massive transfusion protocol, they are in a low blood flow state. And what happens in a low blood flow state? The body vasoconstricts, it clamps down, it only sends blood to the vital organs, right? So when you're giving drugs, even if they are lipid soluble, it may be difficult for them to get to the membranes because you're in a low blood flow state. So they might, you might have to adjust your dosages based on that. Same thing if you have a febrile patient. Febrile patient, the drugs are going to cross those membranes, the blood's going to carry it there faster because they're vasodilated, and you're going to have a higher rate of absorption across the membrane as well. So factors that determine the access of a drug molecule to its site of action. The route of administration, we've talked about that. That's important, whether it's an orally administered drug, or if you gave it IV, or if you gave it inhalational route. The rate of absorption, what is happening at the site. Is it, do you have a situation where you have a patient who is in shock, or a patient who is febrile? Any of those situations affect absorption. Distribution, which we're going to talk about, protein and tissue binding, and rate of elimination or clearance from the system, all determine the access of the drug molecule to the site of injection. So I promised we would talk about passive diffusion and we would talk about active transport, and that is what we're going to do. So passive diffusion, this should be a review for you guys. It is the driving force of movement of drugs. So with passive diffusion, the driving force becomes the concentration gradient. Okay, remember, if you have an area of low concentration and your drug is all accumulated, and now you have injected this drug and you have an area of high concentration, it's going to diffuse across that gradient so that the area of low concentration starts to get some of that drug to that area. So that is what passive diffusion is. It requires no energy. It's just the concentration gradient that is the driving force of drug movement. Okay. Some drugs are charged at physiologic pH. We'll talk about that next week. When a drug is charged, it will not cross the cell membrane in the charged form. And we're talking about weak acids, weak bases. And they exist in a ratio of charged or uncharged molecules at physiologic pH. And then depending upon what happens at that point, whether it's a weak acid or base, when you inject that drug into the bloodstream, will depend upon or will determine the movement of that drug. And like I said, it's a very complicated concept, and we're going to talk about that next week. So to reiterate, a lipid-soluble drug readily moves across most biological membranes, whereas a water-soluble drug penetrates the cell membranes via aqueous channels. They won't just diffuse across the membrane because it's a phospholipid membrane, and you have to have an equally lipid-soluble drug to be able to do that. But water molecules or water-soluble drugs do not sit out there in the plasma. They will cross membranes, but they have to have help. And that help comes in the form of the aqueous channels and active transport. Okay, active transport involves carrier-mediated and solute carriers such as cations and anions and ABC transporters. The ABC transporters are involved. We'll talk about those as well a little bit more in depth, but they are involved in the active transport of the drug across the membranes. You have hydrophilic drugs that require some help to get across the membrane. They're moving against a concentration gradient, and because of that, you have to have ATP. Okay? Hydrophilic drugs bind to transmembrane proteins, and those proteins will shuttle them across the membrane. And it's needed to be able, that energy is needed to be able to move that drug actively across the membrane inside the cell. Okay. An example would be amino acids and glucose. They cross the blood-brain barrier without any issue, they cross the blood-brain barrier with the help of an active transporter. When the blood-brain barrier is disrupted, these drugs will diffuse easily across the membrane and into the central nervous system. So again, amino acids, glucose would be an example of needing an active transport carrier to cross, let's say, the blood-brain barrier. And this slide just summarizes active versus passive transport so that you can see what it looks like and how passive transport requires just a concentration gradient as that driving force, and how drugs or molecules or cations will move across the channel or move across the membrane to the intracellular area. And same thing for active transport. You can see on the right where it requires ATP to be able to get through the channel. Okay, protein binding. That affects the distribution and potency of a drug because it's only the free drug that can move across membranes. And the ability to move is what determines how much drug is available to bind to receptors. Okay, so I'll say that again. Protein binding affects distribution and potency of a drug because only the free drug can move across membranes. So if you have a drug that is bound to a protein, it's not available to move across a membrane, right? Protein binding parallels lipid solubility because these drugs are more likely to bind to proteins and lipids. Albumin is the most abundant protein, has a half-life of about 3 weeks, and it primarily binds to acidic drugs. Lipoproteins such as beta globulin bind to basic drugs. Protein binding is determined by the concentration of drugs in the available proteins. How much albumin does the patient have? How much alpha-1 acid glycoprotein is available? How many lipoproteins do they have? What factors increase or decrease protein availability to bind to drugs? So that helps to determine the amount of protein binding of a drug. The pH of the plasma and the age of the patient. Extremes of age determine how much protein is available to bind with the drug. Again, if it's bound to a protein, it's not active. Anything that's inactive can't move across membranes. Active is the free form of the drug, and active is on the move. So if you think about being active and exercising, active is on the move. Active drugs are moving, and they're moving across membranes. So a drug bound to protein cannot do that. You see, I'm saying this over and over again because this is a very important concept to understand because our drug dosages are altered in patients that have alterations in protein binding. So how do we know what patient group that represents? Well, what about a patient with liver disease? Someone who has cirrhosis or someone who has hepatitis. Those patients would have decreased protein, right? Because they have hypoalbuminemia. And if you don't have protein for drugs that are highly protein bound to bind, then what's going to happen? What will happen is you're going to have more free drug available. So now a drug that is typically greater than 90% protein bound is available to cross membranes, because now it's not greater than 90% protein bound because there's very little protein for it to bind to. So now we have a lot of drug available. It's going to move across the membrane. The patient could receive an excessive dose or be more sensitive to the dose of the drug because there's not enough protein to bind it. Another example of patients that might have decreased fraction of protein would be patients who are acidotic. They may not have enough circulating proteins to bind a highly protein-bound drug. And you ask me, what drug might that be? Well, that's going to be our barbiturates. It's going to be our benzodiazepines. So think about that when you're going to give a patient Versed before going back to the operating room, because you want to decrease amnesia or the risk of, you want to decrease awareness or the risk of awareness, and or you want to decrease anxiety. So you're one of these people that gives all of your patients Versed, because you do not want your patients to remember going back to the operating room and seeing the cold operating room with all the equipment, all the lights. Well, if that patient has a certain chronic condition or an extreme of age, elderly would be another group of patients that have decreased protein binding because they have decreased available protein. So just keep that in mind when you're choosing your drugs and coming up with your anesthetic plan of care. What does my patient look like? Don't get into that habit of just giving cookie cutter anesthesia. Everybody gets the same. I give everybody Versed before they go back to the OR. Well, not everybody needs it. And understand what patient populations that includes. Another group would be newborns. Newborns have decreased protein and the decreased protein binding. So obviously they are more susceptible to sensitivity to any highly protein bound drug. Solubility, like I said, we're going to talk about this more in depth next week because it does deserve an hour of its time on its own here. But drugs have to be lipid soluble to move across membranes. Active moves, inactive does not go anywhere. Diffusion of a drug across the membrane is proportional to the concentration gradient. What other three factors are proportional? It would be solubility, what other three factors affect diffusion? It would be solubility, thickness of the membrane, and molecular weight. Okay, so diffusion of a drug across the membrane is proportional to the concentration gradient. It is also affected by solubility, thickness of the membrane, and molecular weight. So as you learn your basics of anesthesia and your physics and your gas laws, these three factors represent Fick's law of diffusion, okay? And you'll learn a lot about that when we talk about the volatiles. Solubility is also dependent upon oil-to-water coefficients. And what does that mean? Well, it is the ratio of the drug's lipid solubility to water solubility. So it's given in a ratio. The higher the number, the more lipid soluble the drug, which should tell you what? That should tell you that this drug is highly lipid soluble and it's going to move across membranes fairly easily, right? So oil to water coefficient, the larger the number, the greater the lipid solubility. Okay, distribution. Distribution is a reversible process by which a drug leaves the bloodstream and is distributed to extravascular tissues. It is once we inject a drug into the body, where does it go? Where does it go when it leaves the plasma? That's what we're talking about when we talk about distribution. There are several factors that affect distribution, including, I think that's on the next slide here. Yes, lipophilicity, blood flow, capillary permeability, protein binding, which I beat to death in the previous slides, pH of the drug, and the physical properties of the drug. So, lipophilic versus hydrophilic. That's going to determine how easily or readily that drug moves across membrane? Is the drug charged or uncharged? What is the pH of the drug? That's going to affect movement. Acid or base, molecular size, small or large. Small is going to readily move across the membrane. Large is going to have more difficulty, may need an active transport carrier to be able to move across the membrane. Is it a solid? Is it a liquid? Is it a gas? All of those things affect distribution of the drug. Volume of distribution is what we're talking about when we talk about distribution, okay? So you're going to see that on these next slides. And it's a theoretical volume that the drug would have to occupy to produce a concentration in plasma. Remember at the beginning, I talked about your drug being administered in milligrams and grams, and that's your mass, and it's injected into the plasma, and that is your volume compartment. In liters, if you will, because that keeps it easy to keep up with. So now you have a mass, grams or milligrams per liter of volume. So volume of distribution produces that concentration. How much milligrams or grams per liter of volume do you have in the plasma? There are some natural barriers that affect distribution. The blood-brain barrier will affect whether or not drugs can readily cross that membrane. There are certain medications that cannot. We talked about amino acids and glucose need active transporters to cross the blood-brain barrier, but then a drug like atropine very easily crosses the blood-brain barrier. The other natural barrier would be the placental barrier, and that is just Mother Nature working to protect the baby and maintain homeostasis. So volume of distribution describes the relationship between a drug's plasma concentration following a specific dose of medication given. It is a theoretical measure of how a drug distributes throughout the body. It can be viewed as a process of dilution from a highly concentrated solution, that is what is in the syringe that's highly concentrated, into the plasma, which is dilute, okay? And that's what this picture down here represents. So you have your drug here. This is your drug A, and you're going to inject it into a compartment. So this is your plasma concentration. And your plasma concentration is represented by C and then the small p, denotes plasma concentration. So you inject your drug into this compartment here, your plasma, and now you have an amount per volume, okay? And then this over here on the left is your volume of distribution. How much of drug A is distributed throughout this entire compartment, okay? So volume of distribution assumes two things. It assumes that the drug distributes instantaneously. That means you have full equilibration at a time constant of 0. Okay, the little t is your time constant 0. So when you inject a medication, your volume of distribution is instant. So you have instantaneous, drug A is instantaneously going into your volume, your plasma concentration, your compartment, and it equilibrates. So you have full equilibration at that time. It is not subjected to biotransformation or elimination before it fully distributes. Well, what does that mean? It means that it allows the drug to go and fully distribute in that compartment that is there, your container, if you will, before biotransformation or metabolism begins. Okay? So, again, it's a theoretical assumption of this dose of a drug distributing throughout a compartment. All right, and the equation for volume of distribution is at the bottom of the slide. So it's the amount, Q, that's what drug A represents, so we'll change the color of that. So this equals your Q, the amount in your desired concentration, that's here, your plasma concentration, over your time constant. So your time constant is right here, T equals 0, okay? However long it takes to fill up your compartment. Your drug, when you look at concentration per amount, or concentration is your amount per volume, makes sense, right? You give 50 milligrams of drug A into 1 liter compartment, you're going to have your drug distribute 50 milligrams per liter, okay? So it's most concentrated in the syringe before you give it. That makes sense, right? The plasma is a larger compartment, so once you introduce that dose into that compartment, that volume, then it dilutes out. Okay, this is just a review of total body water and how that breaks down into extracellular and intracellular and the volume amounts, and then your extracellular space, your plasma and interstitial volumes. And when we look at drugs and pharmacology, a drug that exceeds total body water, greater than 42 liters, is assumed to be lipophilic. And if a drug is lipophilic, it's going to require a higher dose to achieve a given plasma concentration. So what does that mean? I've told you that lipophilic drugs move across membranes quickly. Patients, our sleep agents are examples of these. Patients go to sleep quickly. So how can you, or why do we need a higher dose of the drug if the drug is moving quickly across the membrane and binding to receptors? Well, the key here is plasma concentration, right? In order to have an effect, you have to have a higher plasma concentration. And the drugs are moving out of the plasma or central compartment and going to the cell membrane and crossing the membrane, and now they're intracellular, okay? So you have a decrease in plasma concentration because the drug is active and moving. So in order to have or to exhibit your effect, you have to increase your dose so that you have more in your plasma concentration. The opposite is true of hydrophilic drugs. So if you have a total body water of less than 42 liters and you have a hydrophilic drug, it'll distribute into some or all of the body water, but it will not distribute into fat. So because of that, you're going to have a lower dose because you have all of this drug that's sitting out there in the plasma concentration and it can't go anywhere, and what was able to move required an active transporter to get there. So now you have to give a lower dose of the drug to achieve a certain plasma concentration. And an example of this is going to be our paralytics. Our paralytic agents are very large molecules, and they're hydrophilic. So when they're injected into the bloodstream, they're restricted to extracellular space, which is your plasma and interstitial fluid. And because of that, they have a very low volume of distribution because they're still in the plasma. They're still in the interstitial space. They haven't gone anywhere. Very little has passed over across membranes. So they have a very low volume of distribution versus a lipophilic drug, which has a very high volume of distribution. Okay, so this is my picture of volume of distribution, and I'm trying to capture that to help you guys understand this concept. I am not an artist. I do not claim to be an artist, which is probably a good thing that I give anesthesia for a living because I sure couldn't make any money doing this. But hopefully you'll be able to look at this picture and it will bring home what I've been kind of hammering in over these last several slides. But you see here at the top, you have again your drug A is a 1 gram dose. Okay, this is drug A. So you have a 1 gram dose of a drug, and you're going to inject that drug into your central compartment. Okay, this is what your compartment looks like before you have drug. So we're going to say that this is plasma, and this is what plasma looks like before you inject the drug. Now you're going to inject your 1 gram of your drug Say we are given 1 gram of ANSEF. So we're giving 1 gram of ANSEF, and we're going to add that to our 1 liter compartment. So now you have this drug going in. So you have this drug now beginning to mix with your plasma. And over a course of time, remember, T equals 0. So over a course of time, our time constant, we're going to reach equilibrium. And when you reach your equilibrium, you now have 1 gram per liter concentration. So that is what volume of distribution essentially, if I could draw it out in this very crude picture here, just what it means is that you're just injecting that drug and it's distributing into the compartment until you reach equilibrium. Again, that is dependent upon several factors. Is ANSEF a lipophilic or a hydrophilic drug? How fast does it get into the compartment, etc. are all things to ask about individual drugs. And as we learn the drug classes, you're going to learn about their volume of distribution. But this is just to give you that foundation, that concept of what it means before we move into compartment models, which will be in the next couple of slides. So we've talked about this, hammered this home to you. Would a drug with a large volume of distribution require a smaller or a larger dose of the drug? It's going to require a larger dose of the drug, right? And this is your formula. Volume of distribution is amount over concentration with your time constant. So to simplify that, volume of distribution helps us to predict whether a drug will accumulate largely in the plasma or in the tissue. Where is the drug going? A large molecular weight drug is typically bound to proteins, and it's not going to pass across those capillary membranes as readily as a drug with low molecular weight. Because of that, because it will not transport over the membrane, then you're going to have higher plasma concentrations. If the plasma concentration is high, the volume of distribution is low. So a highly protein-bound drug is going to have a low volume of distribution because it's bound to proteins. A low molecular weight drug is going to have a higher volume of distribution and a lower plasma concentration. It's going to be our sleep agents. So if you have a drug that has a large volume of distribution, you will need a larger amount of the drug because the plasma concentration, this is the chemistry symbol for concentration, the plasma concentration is decreased. Okay? That's what I'm asking when I ask you a question. Is a drug with a large volume of distribution, do you need to increase or decrease your dose? Now, these are the types of questions you're going to have on your test. I'm not going to have you just repeat to me what volume of distribution means. And I'm not going to give you a question this simple on your test as to whether or not you would need a larger or smaller dose of a drug. I'm going to give you a scenario, and you're going to have to figure out from that scenario, given all the information that you have, if this drug is one that has a large or small volume of distribution. And then you have to tell me what you're going to do. Okay? That's the type of questions you're going to get. They're highly critical thinking questions. Going to have to apply them. This is just your foundational knowledge that you'll take and hopefully be able to apply it to one of your test questions. This is another one of my masterpieces here, if you will, but this is just another drawing for volume of distribution and protein binding. You can see on the left you have the lower volume of distribution, and on the right you have a higher volume of distribution. The yellow represents your drug, and on the left the yellow is bound to, these are little albumin. This is albumin here. And so the drug is protein bound. So because it's protein bound, you have less drug to move across the membrane on the right to the tissue and bind to the receptors on the tissue, which are here, okay? On the right, you have a drug that's has a high volume of distribution, so it has low protein binding. You see there's just not much drug here bound to the albumin. So most of that drug has diffused over across the membrane, and it's at the target tissue and bound to the receptor on the cell. So you have higher volume of distribution because you have a low plasma concentration. And here you have a lower volume of distribution because you have a high plasma concentration. I think that this is a good time to take a break before we start talking about compartment models. So if it's okay with Dr. Rawson, why don't you guys take a 10 or 15 minute break, and then you can resume the lecture after you're finished. The compartmental modeling of pharmacokinetics consists in describing the fate or behavior of a drug in the body. It's depicted as an entity divided into compartments. The drug leaves the site of administration, absorption, to enter a central compartment from which it is both exchanged with peripheral compartments, distribution, and irreversibly eliminated, metabolism and excretion. It allows for the determination of changes in the amount of drug in the body over a unit of time. And from this, we're able to predict drug concentrations in body fluids and tissues. The rate of transfer, that volume of distribution, has a constant, and that constant is represented, you're going to see this in your books and your readings, as a K. So that rate of transfer is the constant K, and it's dependent upon the permeability of barriers, the pH of the compartments, and then the binding capacity at the receptor site. So again, compartment models refer to the rate and extent of distribution of a drug to different tissues and the rate of elimination of a drug. The single compartment model is the simplest model to describe drug distribution and elimination. In a single compartment model, the human body is the box or the compartment, and drug distribution after rapid IV injection all at once into the box results in immediate distribution and equilibration rapidly throughout the compartment. So basically, you inject the drug and it is rapidly distributed. So you see the little figure of the guy here. You inject the medication into the right arm, and instantaneously the entire body has received the drug. So you have immediate equilibration throughout the entire compartment. In this instance, the compartment is one human body. Drug elimination also begins to occur immediately. So that is the hallmark of the single compartment model. You have one phase. You have the phase of distribution and elimination. So the concentration in the plasma and elimination all begin simultaneously. Okay, that is what the single compartment model represents. So the concentrations will only begin to decrease with drug elimination. So it's all or nothing. So everything goes in, everything begins to come out instantaneously. Obviously, the human body does not work that way. Again, another schematic drawing here of a single compartment model. So you have the rapid injection of the drug with immediate distribution. And that's what your little picture here is showing you. So you have your volume of distribution right here in the plasma because you've injected the drug, and now it's all throughout this compartment. You just have the one compartment. And then elimination begins to happen simultaneously. It is the least accurate model because it assumes homogeneous distribution of the drug in the body. It is then eliminated from this volume at a constant concentration dependent rate. Clearly, like I said, this is not what happens in clinical reality. But as a model, it does give us some valuable insight. The volume at the time constant 0 is the volume of distribution for this drug, and that volume is 1 gram per liter. The rate of elimination is described by the rate constant for elimination. Remember, K is your rate constant. So here you have your little k is your rate constant. And then your drug is eliminated based upon the kinetics of elimination at that time. So the human body is far more complex than a single compartment. In the body, when a drug is given in the form of an IV bolus, the entire drug enters the bloodstream immediately. And the absorption process into the plasma is considered to be instantaneous. In most cases, the drug quickly distributes via the circulatory system to potentially all tissues in the body. Uptake of drugs by various tissue organs will occur at varying rates and extents, depending on blood flow to the tissue. So the more blood flow you have to that tissue will increase the uptake of the drug to that tissue. And that's what this middle picture is showing you. You have your high blood flow organs, the liver, the lungs, the heart, and the brain receive the majority of the blood flow. So they uptake the drug first, and then it's distributed to the rest of the compartment. So this compartment model is broken down into your high blood flow organs and then the rest of the body. So it's a 2-compartment model. So uptake is dependent upon blood flow, as well as the lipophilicity of the drug, the molecular weight of the drug, and the binding affinity of the drug for the tissue mass. Most drugs are eliminated from the body either through the kidney or being metabolized in the liver. So this 2-compartment model assumes that the central compartment, the heart, lungs, liver, and brain, comprises tissue that are highly perfused, and the peripheral compartment is everything else, and everything else is less well perfused. So following administration of the drug into that central compartment, the drug will distribute between the central compartment and the peripheral compartment. It does not achieve instantaneous distribution and equilibration between the two, as is depicted in that picture. So remember, from the first single compartment model, you give the drug and the entire human body turns red, right? Because it assumes it's just one body, one model, and everything distributes simultaneously and elimination begins simultaneously. The 2-compartment model, you inject in the central compartment, heart, lung, brains, and liver, get the medication first, and then it distributes to the rest of the body. So there is no assumption of an instantaneous distribution with the 2-compartment model. When you look at the drug concentration profile, this profile here, this graph on the left corner, looks very different from the single compartment model. And that is because now you have a curve that reflects elimination, which is beta, and that is elimination from the central compartment. And then you have distribution to the peripheral compartment, okay? So that is what you're seeing. So your profile shows that elimination and distribution to the peripheral compartment. After that time interval T, a distribution equilibrium is achieved between both. So then the entire human body, after distribution and equilibration, becomes red. And that is assumed to occur all coming from the central compartment. So that is the 2-compartment model of pharmacokinetics. Another rough drawing of the 2-compartment model. So on the left, the blue H is your central and your peripheral compartments connected in the middle, if you will. And you give drug A and you pour it into your central compartment. And the drug starts to go into the central compartment, and it will begin to cross over and distribute out of the central compartment into the peripheral compartment. And that's what we're seeing here. So we're seeing that the drug begins to move both ways, okay? So it'll move over across from the central to the peripheral. And then once equilibration is reached, you have the complete mixing of the drug in the body. It's equilibrated between both compartments, and it's the same. So then the body begins to eliminate the drug. So this is a drawing of a graph of a two-compartment model. It was on your first slide of two-compartment models. And you can see here with the A portion of the drug, this is drug A. Drugs are not confined to the plasma. And you see that here in your picture. So you get your IV bolus of your drug, and instead of being confined to the plasma, it is distributed into multiple theoretical compartments in the body. So when we give a rapid IV bolus, the drug follows its concentration gradient from the central compartment to the peripheral compartments. Again, higher concentration in the plasma, so the drug begins to move out to those peripheral compartments. This quickly reduces the plasma concentration, which is right here, your plasma concentration. And that's reflected by the steep slope of line A, okay? The slope of line A is influenced by the drug's volume of distribution. So this slope will change depending upon whether the drug has a large volume of distribution or a small volume of distribution. As a general rule, the more lipophilic the drug, the larger the volume of distribution and the steeper the slope is, okay? Steeper the slope. Remember this concept when we look at individual classes of anesthetics. It's important that you understand that. Line B represents elimination. Okay, so this is elimination. And as soon as a drug enters the plasma, part of it redistributes based on the concentration gradient between the plasma and the tissues. At the same time, some of the drug in the plasma is already undergoing elimination. So as the plasma concentration continues to decline as a result of continued elimination, the concentration gradient reverses and the drug redistributes from the peripheral to the central compartment. And then this relatively flatter slope that you see here represents drug elimination from the central compartment. So distribution is alpha and elimination is beta, okay, on this graph when you look at it. And that's what it represents. So the curve, the total curve, A plus B, represents plasma concentration over a period of time. This is T, your period of time. Plasma concentration, okay? Plasma concentration over a period of time. It is the summation of line A and line B. The alpha portion of the curve represents distribution. It is also called T1/2 alpha, okay? T1/2 alpha. The beta portion of the curve represents elimination, and you'll see that as T1/2 beta. Just to reiterate, blood flow, it determines the speed organs are exposed to a drug, and it follows cardiac output. So your vessel-rich group would be your brain, lung, heart, liver, kidneys, endocrine glands, endocrine organs. Muscle group, followed by the fat group, which is adipose, tissue, and bone. And then the vessel-poor group, which would be some bone is included in that as well, cartilage and ligament. So to reiterate blood flow, you see here that the vessel-rich group receives 75% of cardiac output, but only has 10% of body mass, versus the muscle group, which has 20% cardiac output and 50% body mass, all the way down to fat group is 5% cardiac output, 20% body mass. Some patients, they may have more fat group than they do muscle group. So that will affect their volume of distribution, as well as the vessel-poor group has 0% cardiac output and yet makes up about 20% of body mass. The multi-compartment model has three distinct phases: distribution, elimination, and slow tissue release. The distribution phase finishes with the drug concentration reaching its peak in the peripheral compartments. The elimination phase is the period during which the main effect on drug concentration is in fact elimination. This phase ends when the slow compartment concentration becomes higher than the tissue concentration, and the total clearance is slowed by the gradual redistribution of the drug into the blood compartment. Concentration time profile shows more than one exponential that describes a compartment. And this multi-compartment model is more applicable to the human body and how our drugs move throughout the compartments. In this model, the three-compartment model, the volumes are predictably identified as V1 through 3 for the three-compartment model. And the kinetics of distribution from one compartment to another are usually described with your K, your rate constant, where X is the compartment from which the drug is distributing and Y is the compartment to which the drug is going. Here, actually, instead of using X or Y, you're going to see, you'll see the 12, you'll see 12 and then 21 as it's coming back. You'll see 34 and 43. So instead of using X or Y, this particular picture uses a number. So in this manner, distribution of a bolus from a central compartment to the peripheral compartment, V1 to V2, would be labeled, here they label it K12. So this is your central compartment. So this is V1, here, V1, and then this becomes V2. And then your constant becomes 12. And then here would be your V3, and your constant would be 3443 as it moves back from the compartment. So what does that mean? That means that you inject a drug into your central compartment in the three-compartment model. So that drug is going to move out of the central compartment, and it's going to move into your V2, V3 compartments. Okay? That is your volume of distribution. And what you're seeing there with the colors, with the blue and the green and the purple, is your tissue concentrations in those compartments at a time constant. Okay? Your K is your rate constant. So that's the rate constant of what is moving out of the central compartment into the peripheral compartments. And then the constant coming back into the central compartment. Because that, how the drug goes in and the compartments that it goes through is the way that the drug is eliminated. So that is what you're seeing right here, and I'll try to put that in a different color. Let's go with yellow right here, okay? So you're seeing elimination of the drug and clearance of the drug from when it's coming back into the central compartment. That's going to be your bottom rate constant here, okay? When it's moving out of these peripheral compartments, coming back into the central compartment to be eliminated. That is what the three-compartment model is representing. Now that we are finished talking about compartment models and volume of distribution, we'll move on and talk about biotransformation. With the compartment models, they're not an absolute, they're theoretical. They are to give you a foundation or some kind of framework for understanding the movement of our drugs, to understand those kinetics, so that before you redose a drug or you choose a specific drug for a patient, that you understand how this drug is moving through the body and what to expect given your specific set of circumstances and conditions with that patient. That is what you are to take away from that, and to understand emergence So when we move into these specific classes of drugs, if you understand their kinetics, then you can time your emergence. You can choose your induction doses wisely based upon patient variability. And so that is what I want you to take away from that, okay? It's not just injecting a drug, oh, they have an onset, it happens in 3 minutes, and this is the effect I should see, and now we're done. That is not what happens when we give our drugs. And because we polymix, and we give a lot of drugs at the same time, we have a lot going on, and some of our drugs are synergistic. They accentuate the other drugs that we've given. Some of them attenuate other drugs that were given. So to understand that movement is important. So now we're going to move over into biotransformation and talk a little bit about metabolism. And what is that? It is the enzymatic process of altering the chemical structure of a molecule. The primary role of metabolism is to change a lipid-soluble, pharmacologically active compound into a water-soluble, pharmacologically inactive byproduct. Creating molecules with greater water solubility increases ionization and decreases their volume of distribution. In turn, this increases their delivery to the kidney for elimination. Since the molecule is ionized, it will be eliminated in the urine instead of undergoing reabsorption from the renal tubule. The GI tract is capable of elimination as well, and the lungs are also capable of elimination. If you have a drug that is lipid soluble and it goes through biotransformation and the body is unable to change that lipid soluble drug into a water soluble byproduct, the lipid soluble drug will be continuously reabsorbed by the renal tubules into the pericapillary fluid and return to the plasma. The drug could theoretically remain in the body for a very long time. This is what is known as a prodrug. An example of this would be phosphopropofol, and that is metabolized by an alkaline phosphatase to its active metabolite, propofol. So if you have a lipophilic drug and the body can't get it metabolized into something water soluble for excretion, it will not be excreted. So it gets sent back to the plasma, it gets recycled, if you will. So it gets recycled and it goes back through this process again until the body is able to break it down into a water-soluble drug to be excreted. Now, sometimes these drugs can't be broken down into a water-soluble drug. If you have someone who has renal failure, they're not able to do that. So we have to use drugs that are renal-friendly for patients who have renal failure or are on dialysis. So that's why understanding this part of kinetics is important. Metabolism is the process of which the drug is altered into another compound, which may be active or inactive, and could be more active or inactive than the parent compound. And an example of this would be morphine broken down into M6G, which is more active than the morphine itself. Another example would be codeine, when metabolized, becomes morphine. And so that too is more active than codeine. Any alteration in the drug allows for excretion from the body. So the goal is to get a lipid-soluble drug to a water-soluble molecule so we can get rid of it. The liver is the primary organ of metabolism, but you can also have metabolism in other sites, and I mentioned this with the lungs and the stomach, the kidneys, placenta, but also in the plasma. When you look at plasma, esterases are widely distributed in red blood cells, and plasma monocytes and macrophages are involved in the clearance of unfractionated and low molecular weight heparins as well as colloids. Also, the plasma esterases, the red blood cell esterases, are responsible for the metabolism of esmolol. So that's another example of breakdown that does not occur in the liver or the kidneys, would be esmolol and the RBC esterases. Hoffman elimination is a series of spontaneous chemical degradation steps that breaks down certain drugs. It is enzyme and organ and age independent, but it is affected by temperature and pH. So drugs that are metabolized through Hoffman elimination are really good choices for patients that have liver failure or who have renal failure, because they are organ independent. They do not require an organ for metabolism, but they are temperature and pH dependent. So if you're giving a patient a drug that requires Hoffman elimination for metabolism, and an example of this would be one of our paralytic drugs, if Hoffman elimination is one of the routes of metabolism and they are febrile, what do you think you would expect? Well, you're probably going to have to dose this drug more frequently because the patient has a high temperature. And if they're febrile, if they're febrile, then you're going to have to redose your drug very often. So if you have someone who isn't febrile, but let's say you have the bear hugger on them and they start to get a little warm and heat up, you might notice that you're having to dose your paralytic more often than you normally would be, but that's because of Hoffman elimination. Okay. Metabolism is regulated by specific cellular enzymes, such as those in the endoplasmic reticulum, the mitochondria, lysosomes, and cytosol. And the significance of this is that it's a protective mechanism. Okay. It increases polarity of the compound, makes it water soluble, so that you have a less active form of the drug to be excreted. It's the metabolites and byproducts of the drug. This helps to restrict penetration through the membrane to keep the patient from receiving too much drug. It reduces distribution and promotes elimination. Okay, that is the significance of metabolism and biotransformation. There are 3 phases to metabolism. Phase 1 results from enzymatic reactions that alter biologic activity via the addition or alteration of a functional molecular group in the chemical structure of the drug. It is the chemical biotransformation of a molecule to a more water-soluble metabolite, and this can happen through oxidation reduction reactions. The cytochrome P450s are responsible for that, as well as methylation hydrolysis reaction, which the esterases are responsible. So if it's a lipophilic drug that you're giving, what this means is that you have the introduction of a polar functional group to render the drug more water soluble. So this introduction through these enzymatic reactions puts a more polar functional group to change that from a lipid soluble to a water soluble molecule. And these alterations can enhance or activate the biologic effects of the parent drug. Or it can introduce a new activity, such as in the case of the prodrugs, like the fospropofol, and certain carcinogenic compounds. Phase 1 reactions typically occur in the liver. So with hydrolysis, you're going to have the insertion of water, that polar compound, into another molecule, and that makes the molecule unstable. It splits the molecule into 2 separate molecules, and this is what we typically see. Hydrolysis is the primary reaction for metabolism of our amide local anesthetics, such as lidocaine, and for one of our paralytic drugs, succinylcholine. Okay, and again, that occurs in the liver, and it is part of phase 1 metabolism. The oxidation reduction reactions, oxidation is a result in the loss of electrons, and reduction is the reaction that results in the gain of electrons. So you have oxidation, losing electrons. I always remembered that the oil rig was the mnemonic that I used when I took chemistry in college. Oil rig, oxidation, and the L would mean loss, and reduction, the G would mean gain. So you have that reduction is the gain of electrons for the molecule. And when you are gaining and losing electrons, the end product becomes the formation of ATP. And ATP is energy, and that energy helps to drive enzymatic metabolism. So you'll get your ester hydrolysis reactions with your esterases, and also Hoffman elimination as well, and then the enzymatic reactions of the cytochrome P450s. With phase 2 metabolism, you have conjugation of a drug or its metabolites with an endogenous molecule. It alters water solubility, results in a highly water-soluble compound that is easy for the body to excrete. Enzymes involved in phase 2 metabolism usually require specific functional groups on their substrates in order for conjugation to occur. So what that means is that sites on the drug where conjugation reactions occur, this goes back to organic chemistry, if any of you guys had it, understanding what those functional groups look like. Carboxyl group, a hydroxyl group, your amino group, those were always the easiest ones to find in a chemical equation, and the sulfohydryl groups. The products of the conjugation reactions have increased molecular weight. So when a conjugation reaction occurs, you have an increase in molecular weight, and when you have an increase in molecular weight, it tends to be less active than the substrates, unlike phase 1 reactions, which often produce active metabolites. So, excuse me, to summarize phase 2, you're going to have that conjugation of a drug, and you'll have into an endogenous molecule. And so some reactions that can occur in phase 2 are glucuronidation, glutathione conjugation, sulfation, and acetylation. And what's happening in these reactions is you have an attachment of polar compounds to drugs to increase their water solubility for excretion in the urine. Glucuronic acid conjugation is the most common, and this also involves the cytochrome P450s. Phase 2 reactions result in glucuronide conjugates that are then removed from the body. Okay. Neonates. Neonates are deficient with glucuronidation conjugating. Their system is deficient, and it's immature as well, and they have an immature renal system. So that increases their vulnerability to drug toxicity, drugs that require phase 2 metabolism. They also have a decrease in the number of cytochrome P450s, and they can have increased bilirubin. So decreased conjugation, decreased cytochrome P450s leads to ability, or decreased conjugation ability leads to drug toxicity. So any drug that requires phase 2 metabolism can lead to drug toxicity in the neonate. Phase 3 metabolism involves those ABC transporters. This is your ATP binding cassette transport proteins. And again, that would be phase 3. Okay, cytochrome P450 system, so your phase 1 enzymes and some of your phase 2 enzymes. So they catalyze the phase 1 reduction oxidation, the redox reactions. They are located on membranes of the hepatic microsomes, the cellular membranes of the endoplasmic reticulum, and inner mitochondrial membrane of the hepatic microsomes. Cytochrome P34A or 3A4 is the most important. It comprises up to 60% of all cytochrome P450 activity. So again, the CYP3A4, most important. And then the CYP2D6 is involved in opioid metabolism. The cytochrome P450s are a superfamily of heme-containing proteins that contain several hundred distinct forms. They are located in cellular membranes in the endoplasmic reticulum and in the inner mitochondrial membrane. The CYP2D6 is responsible for handling approximately 25% of all drugs in current clinical usage and highly involved in the metabolism of opioids, both active and inactive forms. There are more than 100 allelic variants of the CYP2D6. In addition, multiple gene duplications and multiplications can exist in an individual. So what that means is that you can have individual variability in the cytochrome P450 system, and that individual variability can alter or affect metabolism of drugs that require this pathway for breakdown. Cytochrome P450s are the primary metabolic enzyme for numerous drug groups commonly used in anesthesia, including the inhalational agents, the IV hypnotics, opioid analgesics, and local anesthetic agents. Inducers and inhibitors of the cytochrome P450 system influence the function of many drugs. Okay, so if you have enzyme induction, what that means is that there's an increase in the number of cytochrome P450s available. And because you have more enzyme available, you're going to have more rapid drug metabolism. So the drug's going to be broken down quickly. When the drug is broken down quickly, you're going to have a shorter half-life. So you will not have as long of a duration. That's what half-life means. It's broken down, it's shorter, so the duration of action of the drug is shorter because the patient is enzyme induced, which requires frequent redosing because the drug is being metabolized quickly. So some common things that induce the cytochrome P450 system would be smoking, one of the big ones. A lot of patients smoke. So smokers tend to need higher dosages and more frequent dosing because they're having more rapid breakdown of the drug because of their enzyme induction, and they have a shorter duration of action and the half-life is decreased. Alcohol use also induces enzymes, and it's interesting because you'll get these little 85-year-old patients that like to have their little hot toddies every night before they go to bed and their little cocktail, and you think, oh, they're not going to need much because I have this 60-kilogram little 85-year-old lady, and she takes a full 200 of propofol, and it's like you gave her nothing at all. Well, that's because she has some enzyme induction from the alcohol usage of the cytochrome P450 system. Same thing with phenobarbital, rifampin, and flexeril. I can't say it tonight. I'm sorry. So that will increase the enzymes and, again, result in more rapid drug metabolism. Enzyme inhibition will increase the concentration of the drug because you have less enzyme available to break the drug down. So clearance is reduced and half-life is increased. So you're going to have a longer half-life. So your T1 half is longer, which means you're going to have a longer duration of action. An example of these drugs would be Cipro, cimetidine, and isoniazid. So you do not want to redose these drugs more frequently. So you're going to give a dose, and it's going to last forever, and you're going to be like, oh, well, I would expect my patient to respond, or have muscle twitches by now. You've given a paralytic, and you're checking their twitches to see if you need to redose your paralytic, and it's been 45 minutes on a drug that should have gotten some twitches back at 25-30 minutes, and you haven't gotten them back. Well, it's because you have a little bit of enzyme inhibition, and there are certain drugs that can cause that. So the esterases, part of phase 1 metabolism. They are proteases that are specialized and involved in the activation of proenzymes such as those secreted by the pancreas. An example would be acetylcholinesterase. Esterases catalyze the hydrolysis of specific molecules containing the ester group as well as amides. They are found in the liver, erythrocytes, plasma, and GI tract. Cholinesterases have particular relevance to anesthesia. Again, acetylcholinesterase, and then pseudocholinesterase, which is the one just below that. Acetylcholinesterase plays a key role in regulating cholinergic transmission, and it is a target for drug therapy in autonomic central nervous system and neuromuscular disorders. Pseudocholinesterase is also known as plasmacholinesterase and is involved in the metabolism of our paralytics and some of our local anesthetics. We'll learn more about that next semester. Phase 2 are the transferases. You don't really need to know that much about these at this particular point in time. We'll talk about them with each individual drug class, but it's the predominant enzyme type for phase 2 metabolic drug reactions. It's responsible for attaching water-soluble sugars, amino acids, or salts to their substrates to form metabolite that can be excreted. They may exhibit genetic or environmental variations, and as a result can alter the metabolism of drugs that require this pathway for biotransformation and elimination. Okay, the last topic we're going to talk about today is elimination. And when we talk about elimination, we talk about clearance of the drug from the body. So the kidney is the main organ of elimination. Drugs are excreted in an unaltered form or as a metabolite. They undergo metabolism to a water-soluble form in order to be eliminated by the kidney. The body keeps recycling until it is suitable for elimination. Like I said earlier, if a lipophilic drug undergoes biotransformation and it is not water-soluble, the body will continue to recycle until it is. So clearance is the volume of plasma that is cleared of a drug per unit of time. It is directly proportional to blood flow to the clearing organ, extraction ratio, and drug dose. Directly proportional. What that means is as blood flow to the clearing organ goes up, clearance goes up, extraction ratio goes up, etc. Directly proportional. It's inversely proportional to half-life and drug concentration in the central compartment. So as one goes up, the other goes down. Clearing organs are the liver, kidney, Hoffman elimination, and ester hydrolysis, and the lungs can also be a clearing organ as well. Half-life versus half-time. These two definitions are used interchangeably. You might read one book, it says half-time, the other one says half-life. For our purposes, we're going to use them as the same, and we're going to talk about half-life instead of half-time. So it's the time it takes for 50% of the drug to be removed from the plasma during elimination. Another way to say it is that it is the time that it takes for the plasma concentration of a drug to fall by 50%. Half-life is important in understanding duration of action, time to steady state, and dosing intervals after the initial redistribution phase. When the rate of drug removal from the plasma is not the same as the rate of drug removal from the body, the elimination half-life will be different. Half-life varies directly with volume of distribution and inversely with clearance. These relationships make sense given that a larger volume will take longer to clear, and a higher clearance will obviously speed the decline of drug levels. So we talk about directly related to volume of distribution. The larger the volume of distribution, the longer it takes for the drug to clear. The higher the clearance, because it's inversely related to half-time, the higher the clearance, the lower the half-life, okay? Which means the duration of action is decreased. So your half-life is not as long. You're going to speed that up as your clearance is higher, okay? And this is the equation for half-life. So half-life, T1 half, equals your time constant, 0.693 times volume of distribution. And it is divided or inversely proportional to clearance. So this chart represents half-life and just kind of gives you an example of the process of half-life and how drugs are eliminated from the body. If we give or inject 100% of a drug, we have 0% of that has been eliminated at time constant 0. Okay, your half-life T1 half 0. And that's what this is equivalent to, T1/2 0. So at 1 half-life, you have 50% of the drug eliminated and 50% remains. 2 half-lives, 75% is eliminated and 25% remains, until you get down to 4 half-lives, where you have around 93–94% of the drug has been eliminated and 6% remains. And by 5 half-lives, 96–97% of the drug is eliminated and 3% of the drug remains. It takes 4 to 5 half-lives for a drug to be eliminated from the body. Okay, that is the take-home message from this chart. 4 to 5 half-lives for a drug to be fully eliminated. This is another example. I give you a dose here. You're given a drug, 500 milligrams. Let's say that that's 500 milligrams of drug A, okay? And the half-life is 4 hours. As you can see over here, your time is all by 4. So the half-life is 4 hours. So at 1 half-life, you have approximately 50% of the drug left, which is 250 milligrams. 8 hours, it's 125. Down to the 4 to 5 half-lives. At 16 and 20 hours, you have 31 milligrams and 15 milligrams, respectively, of the drug left. So again, 4 to 5 half-lives for the drug to be eliminated. Okay, moving on from half-life to steady state. Steady state occurs when the amount of drug entering the body is equivalent to the amount of drug being eliminated from the body. There is a stable plasma concentration. All compartments have equilibrated, although the total amount of drug may be different in different compartments. Steady state is achieved after 5 half-lives. So steady state refers to continuous infusions, and it maintains a steady concentration in the plasma, okay? Hence the name steady state. All right, it's the point of maximum effect of a drug. It's attained after 4 to 5 half-lives, and the infusion rate or dosing interval must be equal to the rate of drug clearance by metabolism and elimination. So at this point, what's going in and the dosing interval equals what is being cleared and metabolized in the body. It's inversely proportional to drug clearance. Liver and renal disease increase steady state concentration. Makes sense, right? You're going to have a higher steady state concentration because you cannot metabolize and eliminate the drug. So the concentration is going to be high. So again, steady state refers to the rate of administration, and it's equal to the rate of elimination. Another way to look at steady state is it's an equilibrium state in which the amount of drug going in equals the amount being eliminated, and I just mentioned that a few minutes ago. It means that that the amount in the plasma is stable. Even though that you have the steady state concentration and the amount of drug in the plasma is stable, and you have the same amount going in that's being eliminated, it doesn't necessarily mean that the total amount of drug in each compartment is the same. Actually, the total amount in each compartment can be very different, because remember, as the drugs go into the compartment, they have to leave the body the way they go in. So you go through central to peripheral to, all the way down to those zero perfused areas, the bone, cartilage, etc., and it exits back out the body in reverse manner. So it comes back through all those groups before total elimination occurs. Context-sensitive half-time is a longer infusion, and so it is the time required for the plasma concentration to decline by 50% after the infusion has stopped. So with a longer infusion, you have more time to fill up those peripheral compartments. Therefore, there's more drug that needs to be eliminated, and it will have a longer elimination half-time. And this is true because the drug has been running for a specific amount of time. And so all these compartments are equilibrated And now that you turn the drug off, your elimination half-time is going to be longer because those compartments are full and the drug has to come back through that same course that it went in. So context in this sense means time, okay, and time means you have a longer elimination half-time. All right, and this all is dependent upon the duration of drug administration. How long was that infusion running? And then you have other variabilities that you look at, such as body habitus, extremes of age, etc. Hepatic clearance is the product of liver blood flow. And with liver blood flow, how much is delivered to the liver, okay? How much blood is going to the liver, how much drug is being delivered to the liver, and with the extraction ratio, how much of the drug is being removed by the liver, okay? That is what hepatic extraction ratio is referring to. Hepatic clearance is categorized as flow-limited elimination or capacity-limited elimination. And the extraction ratio measures how much of the drug is delivered to the clearing organ, in this case the liver, versus how much is removed. An extraction ratio of 1 means that 100% of the drug delivered is removed. So extraction ratio of 1 means that 100% of the drug delivered is removed. An extraction ratio of 0.5 means that 50% of the drug delivered is removed. Okay? The higher the extraction ratio, the more drug that is delivered and removed. Flow-limited elimination and capacity-limited elimination is what I mentioned when we talked about extraction ratios. Increased blood flow equals increased clearance. That makes sense, right? They're directly proportional. Decreased blood flow equals decreased clearance. So with flow-limited elimination, you have an extraction ratio less than 7, okay? And clearance is dependent on the liver for blood flow. Capacity-limited elimination, you have an extraction ratio of less than 3, and you have a very small amount of drug that's being removed per unit of time. So the blood flow to the liver minimally impacts clearance. So with flow-limited elimination, blood flow impacts clearance significantly because you have higher blood flow to the liver. And again, clearance and blood flow are directly proportional. But with capacity limited, your extraction ratio is less than 0.3, so blood flow minimally impacts the clearance. But what does impact clearance with capacity limited elimination is enzymes. So your cytochrome P450s impact clearance with capacity limited because here you're dealing with the liver's ability to extract the drug from the blood. So if you have enzyme induction, patient smokes, they're enzyme induced, your capacity limited elimination is going to go up, so you're going to have increased clearance. If you have enzyme inhibition, then your capacity limited elimination is going to go down and you'll have decreased clearance. So that's the difference between those two. Renal clearance is a key function to elimination of metabolic waste into the urine, and it is dependent upon renal function, and that is just common physiological sense, right? If you have poor kidneys and they're not working properly, you're not going to excrete your drugs. The fate of a drug is determined by its polarity, and we've talked about that. If it's water soluble, it's going to be excreted. If it's not, it's going to be recycled until it is ready to be excreted. And the pH of glomerular fluid. Hydrophilic drugs are excreted unchanged. Lipophilic drugs must undergo metabolic reactions, those phase 1, phase 2, phase 3 reactions, to increase their water solubility. Factors such as advanced age, prematurity, low cardiac output states, hepatorenal syndrome, etc., all affect renal clearance. And we talked about how the drugs that are lipophilic go back through and are reabsorbed into the peritubular fluid and keep being recycled until they have a polar group added to them to make them more water soluble. With renal clearance, there's two processes that deliver drugs to the urine. Glomerular filtration is the first one. If a drug is not bound to plasma proteins, it'll be freely filtered by the glomerulus. Drugs that are highly protein bound are resistant to glomerular filtration. And then the second process is organic anion and cation transporters. Transport proteins located in the proximal renal tubules actively secrete organic acids and bases into the urine. Urine pH also influences whether drugs are excreted in the urine or reabsorbed. Likes dissolve likes. Okay? Likes dissolve likes. And remember that because we're going to talk about that next week with pKa and ionization. Likes dissolve likes. Likes love likes. Okay? So acidic urine favors the reabsorption of acidic drugs. And if it favors the reabsorption of an acidic drug, it must favor the excretion of a basic drug and vice versa. Basic urine favors the reabsorption of basic drugs and excretion of acidic urine. So that is the process of renal clearance. It is dependent upon glomerular filtration and your anion and cation transporters, as well as urine pH will determine whether or not a drug is reabsorbed or excreted. All right, last but not least are the kinetic models for elimination. For the majority of drugs, the rate of metabolism is dependent on two factors. We've talked about this during this entire lecture. The concentration of drug at the site of metabolism, which is influenced by the blood flow to the site, right? Because concentration is the plasma concentration. So if you got good blood flow to the site, that will impact the concentration of the drug at the site of metabolism. And the intrinsic rate of the metabolic process. And this can be influenced by several factors, including genetics, enzyme inductions, and enzyme inhibition. So the first kinetic model we're going to talk about is first-order kinetics. So with first-order kinetics, basically what is happening is that the enzymes metabolize a constant fraction of a drug, and that drug is then eliminated per unit of time. And the amount of drug decreases the amount of drug decreases at a rate that is proportional to the amount of drug remaining in the body. Say that again. Amount of drug decreases at a rate that is proportional to the amount of drug remaining in the body. It describes a situation where there's less drug than enzyme. So with first order kinetics, there is no saturation. Okay, you do not get a saturation of the drug because you have drugs that are being broken down through this particular mechanism. And most of the drugs are eliminated by this process. So a constant fraction of drug is eliminated per unit of time. It is logarithmic, and you can see from the curve you have just the regular log curve in this graph. So we're going to do this chart together. This is a first order kinetics chart, and in this chart we have given 1,000 milligrams of a drug, okay? And this drug is eliminated via first order kinetics, and it has a half-life of 8 hours. So how much of the drug will be left after 24 hours? So if the first half-life is at 8 hours, then we have about 500 milligrams left of the drug. Two half-lives would be 16 hours, and we would have 250 milligrams of the drug. And at 24 hours, which is what the question is asking, how much of the drug is left, we can expect about 125 milligrams of the drug. Okay, so one half-life is equivalent to 50% of the drug being eliminated. And remember, it takes 4 to 5 half-lives for a drug to be eliminated. All right, 4 to 5 half-lives to get 96% of the drug eliminated. Okay, zero order or linear kinetics, and you can see from this graph it's a straight line, so it's linear. So we look at this kinetic model. Enzymes metabolize a constant amount of drug per unit of time. So more drug than enzyme, and therefore the biotransformation process becomes saturated. So you have saturated metabolism at this point. There are some drugs that undergo zero-order kinetics, and those drugs are aspirin, phenytoin, alcohol, warfarin, heparin, and theophylline. All undergo zero-order kinetics. So again, zero-order kinetics, there's not enough enzyme available to metabolize all the drug that's delivered to it. Okay, and another way that you can think of this is think about a bus. So you have a bus, and the bus is going to be the enzyme. And the bus comes to a stop, and you have these people at the bus stop that are wanting to get on the bus. So they represent the drug molecule. But the bus only has 10 seats, and you've got 40 people wanting to get onto the bus. And it can only pick up 10 people at a time. So no matter how many people are standing in line, only 10 people can ride the bus at any given time. So that's what zero-order kinetics is. You have a certain amount of enzymes available, and no matter how much of the drug is delivered to those enzymes, they can only metabolize so much of the drug per unit of time. Okay? And that's why if you think about drinking too much and becoming intoxicated and the effects of alcohol, that's what's happening. You drink and consume alcohol, but you only have X number of cytochrome P450s to break it down. And so as you saturate and you have saturated metabolism and you have all this alcohol in your system, only X amount can be eliminated per hour. Let's use hour as our unit of time. So that's what gets delivered to the enzymes for metabolism. And that's why you have excessive alcohol on board and you get the effects of intoxication because your body can't get rid of it as fast as you're consuming it. So that would be an example of zero-order kinetics. So in summary, pharmacokinetics is the movement of the drug throughout the body. Many of our anesthetic agents have large volumes of distribution, and that's important to know as we dose and redose our drugs, and understanding how that volume of distribution in the presence of certain coexisting conditions can affect our drug kinetics, as well as metabolism and elimination of drugs is dependent upon many factors, and that too includes coexisting conditions and extremes of age. Now the next presentation we're going to talk about pharmacodynamics and how that applies to the foundation of anesthesia, and then like I said, with each drug class we're going to go into the pharmacokinetics and pharmacodynamics explicitly for those drugs.